Hello, everybody. Good afternoon. My name is Garrett Schmidt. I am the managing editor for ACO Exhibit Hall, and I'd like to welcome you all to the final in a three-part series by HealthEC called Getting Your ACO Through the Crisis. This has been a really timely and valuable series. Today's final session is called The Power Over Uncertainty, Preparing for What's Next for VBCs. A few items of note before we get started. You are all in listen-only mode as attendees, so you don't need to worry about muting your microphone. That's been done for you. The webinar is being recorded, and so afterwards, I'm going to send you all an email, and that'll have a link to where you can watch the webinar, download the slides, and I hope you would share that with colleagues and have a chance to rewatch that if you would like. And then finally, we want to hear from you during the presentation, and we're going to have a Q&A session at the end. So at any time during the presentation, please submit questions to our presenters using the attendee module. There's a question section of that attendee module that you should be able to submit questions there. No one else will be able to see who you are or what questions you submitted, so you can do that. And we're going to get to as many of those as we can. For those that we are not able to get to today in the allotted time, we'll make sure to get back to you via email to answer those questions later. So without further ado, our presenters today, as have been in the previous part 1 and 2, is Dr. Jenifer Jaeger, who's the Senior Medical Director, and Dr. Sanjay Seth, EVP CMIO, both of HealthEC. So welcome, guys.
Thank you. Happy to be here.
Hi, Dr. Jaeger. We have our own social distancing. And thank you all for joining. And as Garrett indicated, this is me on one side and the pretty Dr. Jaeger on the other. And hopefully both of us will get you through this session as well. We thought that a little bit about who we are in HealthEC and then talk about just recap what happened in the first 2 webinars of this series, and then focusing on what we would do today, power over uncertainty, and really the choice of words was intentional. How do we overcome the uncertainty? How do we prepare for the uncertainty so that we don't end up with our backs to the wall? Little bit about HealthEC. Actually, before that, Dr. Jaeger, why don't you give us a little background about yourself and how and so that it is understood why it's relevant to what we are talking about.
Certainly. Hi, everybody. Thank you for joining us. So I have been with HealthEC as the Senior Medical Director now going around 5 months or maybe 6 months. Shortly after I arrived is when the pandemic arrived in the United States. My experience with epidemiology and infectious diseases it goes back to the last several years where I've been in public health. I was most recently the medical director, interim medical director, and then director of infectious diseases and population health for the Boston Public Health Commission, which is the Boston City's health department, where I was working on hepatitis A outbreak and control and various other infectious disease outbreaks. And prior to that, I was with the New York City Health Department as the executive director for the Bureau of Healthcare Systems Readiness addressing Ebola in New York City. And the training I received in all of this is actually through CDC as an epidemic intelligence service officer, where I was the medical clinical team lead with pandemic H1N1 when it first arrived in the United States. So I have a little bit of experience in working in the area of epidemiology, and I'm a physician trained in pediatric infectious diseases and pediatric urgent care.
Thanks, Dr. Jaeger. And this is Dr. Seth, and I have an extensive background in addition to being a physician, managing hospitals and providers and ACOs So have different perspectives on the same data points, and hopefully that lends that flavor to how we speak and what we think about and how the platform is developed on our end. So HealthEC is a full population health technology and advisory service firm, and we manage over 50 organizations, lots of ACOs with or provider organizations with commercial plans and Medicare plans, including managing the Medicaid population in a couple of states. So we have some good experience in looking at data for different populations as well. We do submit, we are a MIPS registry, and we have been certified to extract data for ECQMs from the EMR data as well as claims data. So we feel that we've reached that level of expertise that helps us talk about all of these things, and certainly doing all of this putting the data into a warehouse from all sources and modeling the data from different perspectives is why we think we do it well, and certainly have helped a lot of our clients in achieving some successes with population health and provider and payer contract negotiations. We're all going through this experience of COVID, so I'm sure it's on the top of all our minds, and it should be. This is what we had predicted when we did our first webinar. I think it was in April, and I think even as conservative as we were in April, I think it is certainly not doing this. The red line has remained flat between April, May, June, most of June. So we're beginning to see that maybe it's a longer recovery period, and certainly there are a lot of assumptions that went into this, including capacity and opening and closing, and now we are seeing a resurgence of some cases in some states. And that's the other difficulty we have in this COVID situation is, and I'm going to ask Dr. Jaeger to focus on that with the next slide of what are the lessons we've learned so far from COVID, as well as our first topic of why value-based contracts in this environment, and then certainly why we should all be moving towards risk. So Dr. Jaeger, why don't you give us a little quick summary of both the COVID situation and what we are seeing now from pandemic, including what we covered earlier.
Yes, I think one of the biggest lessons that we can take from this is that, and I was first taught this as an infectious disease fellow, which is that the dumbest virus is smarter than the smartest doctor. And I think we're certainly seeing that now. Most of the assumptions that we made have not significantly panned out. So what have we learned over the past 5 months regarding COVID, and particularly how the pandemic is impacting healthcare and delivery? With regard to who is susceptible, we find that the highest risk groups have not been those traditionally impacted. We're not seeing it in the young, and we're not seeing it among individuals who are immunosuppressed. And different from what was reported outside of the United States, we're seeing racial disparities as a major issue regarding both infection and mortality rates. In terms of vulnerability, as I mentioned, we're not really seeing the impact as high as we would have expected among individuals who are immunosuppressed or pregnant. And that seems to be due to their lack of a robust pro-inflammatory response, meaning their body isn't causing quite the reaction that individuals who have a strong immune system are experiencing. Is there a prevention strategy? And I think that this is one of the biggest issues that we're facing, and I'm not going to be political, of course, here, but I think the lack of a national strategy has hampered our response capability, as we are seeing now with an increase in cases, as Dr. Seths just mentioned. They began to decrease somewhat, but somewhat slightly, in fact, and have had a swift increase now, even higher, daily case counts higher than at our peak. So local health departments, healthcare, and even health plans are designing their own approach, making it difficult to establish a coordinated plan as well. And I think luckily we're seeing the private sector stepping up in terms of the population health management technology, contact tracing, and treatment options and vaccine development. Is there a standard treatment or management protocol? And that goes along with the lack of a preventive strategy. We really don't. And part of that has been, again, hampered by understanding how the virus reacts, and the fact that coronavirus is the etiology of the common cold. If it had been easy to make a vaccine, we all would have had a vaccine to the common cold a long time ago. So we don't have a standard treatment program. And there, as everybody here is probably well aware, there were issues with hydroxychloroquine. We thought it worked. We thought maybe it doesn't work. So there have been issues there as well. How does it travel? Well, we've had all sorts of concerns with regard to, is it contact, is it droplet? And now we're realizing that, in fact, there is some aspect of aerosolization, and wearing face masks is important, even though you can see it's bothersome to a number of people. But that's one of the key issues that we need to address. And what makes sense to flatten the curve? So we're all tired of social distancing now, but we have to address how to move forward so that the second 6 months of cases doesn't top the first 6 months. In terms of contact tracing, it's important for us to bring to scale and accomplish contact tracing in real time. Again, this is going to require some technology, but without a good test, it's going to be difficult to do targeted contact tracing and identification of the limited number, the smallest number that we would need to isolate in order to prevent spread. So that leads us to adapting to the new normal, which hopefully there are lessons that we learn and make substantive changes. I don't think we need to go back to the way it was completely, and in fact decreasing the excess use of tests or encounters where telehealth will not just suffice, but be better. We want to retain high patient contact touch points, but we can do that over the phone or video. And I think that we have a slide later on actually demonstrating the extraordinary waste that we have in our healthcare system. So I think there's a number of different things that we can do in terms of chronic care management and good preventive health and well-care checks that will actually improve health outcomes and provide high quality care. And that's the purpose of value-based contracts. The economic strain due to decrease non-emergent ED visits and inpatient visits, particularly surgery and other procedures due to COVID, has led to a significant drop in physician practice revenue, and about 50% of revenue was seen between a drop of 50% between March and May of 2020, and it's felt across the spectrum. Again, predominantly with those individuals who are doing procedures, but even those who are doing primary care practice. So value-based care really offers true transformation in this sense, and it's smart in the context of this pandemic, being able to see how there are shared savings that are available for meeting benchmarks on reducing spending in the context of meeting quality benchmarks. We're seeing the uncoupling of encounter-based visits, and value-based care incentivizes providers or practices to move from fee-for-service to pay-for-performance, and encouraging alternatives to in-office encounters. So again, the emphasis on telehealth and, as I mentioned before, strong primary, preventive, and chronic care management. The meeting of benchmarks for spending due to decreased utilization can result in increased savings for providers that are engaging in value-based healthcare, and so or value-based contracts. And so really that's the biggest take home, I think, of at least this entire slide of sort of most of what I'll be talking about, and forces collaborative arrangements and minimizes risk to providers by risk sharing among both providers and patients. There's the as I said, focus on preventive care and patient engagement, and endorses the use of protocols to standardize care, reducing waste and unnecessary cost, and again, providing only high value care. Risk-based is something that, although we may not see new providers and organizations entering into risk-based contracts, they're not going to disappear. They may be put on hold a little bit, but they're not going to be disappearing. It allows for common payer and provider goals, or it must align payer and private goals in moving to value-based healthcare. And plans, with the focus of ensuring sustainability and profitability, want to shift to a model in which providers will take contractual responsibility for the cost and quality of their patient population. Two major drivers in this transition are providers demand to shift to value and a share of premium risk. And for purchasers, they demand value-based contracts to control costs through narrow networks, differential pricing arrangements with high-value providers, and new benefit structures. There's severity-based agreements and employer premiums as opposed to total cost of care, and collaborative agreements, as I said, moving to fixed cost-based agreements or bundled payments models. So providers are reimbursed on a pay-for-episode of care basis, which incentivizing providers to collaborate across a continuum of care to deliver high quality and low cost healthcare. There's no incentive in this model to focus on preventive care, since this model allows payment to begin at the time of diagnosis. But there is significant incentive to ensure that there are no gaps in care when a patient moves from one care setting to the next through onto recovery. Contract for comprehensive services with partners and first dollar benefit from reduced utilization, meaning insurance policies with no deductible, where the insurer would assume payment once the insurable event occurs. And then, of course, technology to support data collection and analysis is key to support any type of risk-based contract. So I think I turn this over to Dr. Seth to provide a little bit more information about what's available.
No, thanks, Dr. Jaeger. And really the issue was that as we all negotiate value-based contracts, which we think the shared savings programs with reduced total expenditure are going to see larger savings and incentives unless the payer or CMS changes rules now on us. And that point will come back again, is how do you prevent a unilateral change of terms going down the road, and that should be included in your renegotiation with risk. Again, with risk, it means higher risk, but also means higher reward. And instead of getting only a percentage of the shared savings, you get all the shared savings, and that's the first dollar benefit from your utilization. Without technology, we know that this is going to be harder. So when we are moving towards risk, what are different issues that we are beginning to see or have seen in risk-based agreements, and we thought we would highlight a few of the benchmarks and talk about them. So one of the common ways of negotiating a risk-based agreement is talking about total cost of care as a medical loss ratio, an MLR contract. And we've seen MLRs, we've seen some lower, but typically we are looking at them at somewhere between 82 and 93%. Basically, what does that mean? That the government has mandated that every health plan spends at least 85% of the premiums they earn on healthcare, and so plans try to shift issues or services into qualifying them as healthcare services so that they keep more of the money. With Medicaid plans, we see a much higher MLR. Bottom line is, the lower the MLR or the benchmark, the easier it is to perform. So if you can, during your negotiations, start lower, start at 75, 78%, and then come up. It'll be hard, but that's where we would suggest. The other piece that the health plans focus on with their reportings to CMS is their star rating on quality measures, the HEDIS reporting. And the reason for that is if you have a health plan with lower than 3 stars, their application to expand their marketplace is usually denied by CMS. So they don't get a new area unless they're meeting a minimum of a 3-star rating when they're applying for a new market or as a new plan. So that data is available on CMS's site, and you can see by state, by health plan, or by MCO, what is their star rating. And if you focus on the guys who are between 2 and 3.5, you would get, you would have a little bit of leverage. And the leverage is that some of these quality measures and patient satisfaction measures are totally dependent on what's in the EMR and what the practice does. So you have greater control on improving those scores and use that lever to negotiate a better deal. Be careful when you're negotiating a contract. The payers do look at it from enrollment types, dual eligibles and the elderly versus disabled, and all of those categories, age group category, enrollment types, far more prevalent in the Medicaid marketplace, but make sure that you negotiate appropriately by enrollment type. And one of the things that we fail to focus on is this continuous enrollment. So HEDIS measures are typically require a continuous enrollment for the entire measurement period. So if a patient was only in the plan for 11 out of 12 months, it could be a double-edged sword. Their cost is also excluded, and their quality measure, they're excluded from quality benchmarks. But with Medicare and some plans, we're beginning to see that they would include the cost, but they can't report on them for HEDIS. So take advantage of those terms on quality, and insist on a continuous enrollment for quality, and at least make it 9 months. If you don't get 12, at least shoot for 9. One of the things that they do look for total cost of care is having a corridor. So they don't want to the payers do not want to pay out all the savings. They say, okay, we'll give you a corridor where your savings is capped, but then your upside and downside should be capped at the same level. We have seen contracts, and we have helped some of our organization negotiate an unequal corridor, a smaller downside, a higher upside. The OCM practices from CMS do that. In the risk, they have a 2% downside and a 4% upside. So it's not unprecedented to negotiate a different corridor for up and down, but the payers get a little lazy and try to make it one number for both. The individual cap costs are extremely important. The payer is going to try and move it down, and that's because they want minimum. They have the opportunity to then renegotiate their reinsurance program for a start, whereas a higher cap is better for the providers, that the high cost patients going above 150,000 in this example, only the dollars up to 150 will get included. So it is a double-edged sword again. I would love to have a cap of 100,000, but then when I'm hedging my risk, which is a couple of points below, I will have to pay a higher premium if my cap is low. So you have to model that out to see what one makes sense. Of course, in total cost of care, don't forget to have these exclusions on procedures and services and drugs and age groups. And some of the examples are here: transplants, implants, use of neonatal intensive care units, or substance abuse disorder mother and babies, or you take all the TANF babies, they do seem to have runaway costs. So think about what exclusions. And then, of course, the last point of shifting the burden of services that you do not have in your network. And one of the topics we talked about is make sure you understand your own organization and all the services you offer. So make sure that in the contract, the shift or shift the burden of getting services for your patients that you do not have to the payer's responsibilities, and take that out of the cost and make that part of the exclusion, as well as make sure that you're not being subjected to a high cost network of providers that you don't have. So it's not easy. It doesn't happen on the first go around. But if you've been getting claim files from the payer, you will be able to identify this network and the price and look at that to see if the fee schedules being offered to the providers in and around your neighborhood or your region are appropriate and not disproportionate. Because the payers do negotiate with the hospitals and these service providers as a quid pro quo for one service against another, and make sure that the services that you're responsible for in total cost of care do not have the highest highest cost providers. So that's something that we think that is important. Also be aware of all the new programs from CMS, and here are a few that I've talked about that we've listed here. And Primary Care First is one of the programs, and started off this year. I think it's going to gain some momentum unless they put them on pause, and you'll see some of that in Dr. Jaeger's analysis of what to expect from CMS in the near future. But functioning like a mini ACO for an individual provider in a practice is something that they are experimenting. Maryland has a Primary Care First waiver program for the entire state, and where we are also beginning to see some advanced payments, care coordination fees being paid to the providers. That's based on the risk of stratification of their patients. For larger organizations, we've seen this direct contracting, and where we are talking about capitation somewhere around the 7% of total annual Medicare costs for fee-for-service. They're talking about some shared savings opportunities there as well. And they have two other models. One is that's global, tied to capitated for primary care, but all services, and a list of preferred providers for the organization, and as well as direct contracting that's based on geography, where we are talking about regions. And I don't know how that was even permitted, because the FTC would have something to say on market dominance, but that's what they have had approved, and we are beginning to see that. I will not be surprised. In fact, I know for a fact that payers have begun to do this too. They're just calling it by a different name: preferred networks, narrow networks, centers of excellence. Those are all synonyms for direct contracting based on geography and services. So I think we are on our way to see that in this with the same terminology. Some of the other things, very interesting, very innovative in terms of CMMI, and talking about a single value-based activity for a target population, and enhanced payments or discount services for that, where they're including cost sharing changes. So in cost sharing, meaning higher and lower deductibles, and higher and lower deductibles are discouraging use of what they've begun to phrase as low value care providers, eliminating some of the barriers, and certainly with cost sharing, aligning out of pocket expenses and copays. What we have begun to hear a lot is both Medicare, Medicaid, commercial payers all looking to find a way to target chronic conditions, socioeconomic characteristics, or certainly incentivizing a preferred use of Part D prescription plans in affiliation or association with the pharmaceutical companies. However, this is a focus from CMS, and I've asked Dr. Jaeger to see if she could, or one of us would address what trends we are seeing both from the payer side and the provider side. In Dr. Jaeger, do you want me to handle this, or would you be comfortable talking about it?
Yeah, I'll start us off, and then please join in and clarify as needed. So, as Dr. set the slide up, we're looking at trends here, both comparing what we're seeing from the payer side and then what we're seeing from the provider side. And as you probably can tell before you even read the slide, they are sometimes in direct contradiction to one another, beginning with providers as organizers of care, requiring strong leadership and certainly a deep bench, but which would also put some onus on them for the operations and technology as well, and then doesn't really give them a great market advantage with a smaller infrastructure. Whereas the provider trends that we're seeing now is to create a provider organizations that actually support a greater efficiency, comprehensive care along the continuum of healthcare, and concurrent with a larger market share. And these go by different names, IDN, the Independent Delivery Network, or clinically integrated networks. Some of these, certainly CIN is really a legal definition, and ACO for just the organization in general, looking at efficiency and comprehensiveness. And something that Dr. Seth found, which I had not heard this term until today, which is systemness, which describes a complex healthcare system, delivery system, where patient-focused and seamless high-quality care is delivered across the many parts of the system to maximize value for customers, and working on the triple or now the quadruple aim collectively. It requires aligning population health management goals, cost and quality improvement for healthcare payers and providers, and also aligns incentives moving toward an integration and preparing for financial risk. Then going back to the payer side, in looking at contracting for pharmaceuticals, what we're increasingly seeing are mergers, acquisitions, or other types of relationships among payers and drug manufacturers, particularly pharmacy benefit managers, with examples that we're seeing now with Walgreens, Walmart, CVS, and Aetna, contracting for pharmaceutical specialties that would allow control of the formulary and drug utilization as well as cost. And this is really in direct contrast to what providers would want, which is, in addition to controlling drug costs, physicians are looking for improved drugs with improved patient outcomes. And this is certainly one of the areas where payers and providers need to better align themselves. On the payer side, we're seeing continued lack of transparency, lack of real-time analytics, and changing agreements midstream, perhaps to find a way of not paying out bonuses, or to, and that the payers want to restrict data because it would otherwise bring to the surface different fee schedules that payers have with different providers. On the other side, providers are really becoming much more informed on data, cost, and outliers. They're looking at patient services and programs across all operational levels. And this is certainly supported by greater familiarity with health IT and population health management. Providers are asking for more data to better manage their performance and to measure quality and documenting better patient outcomes. So they're saying they can't, providers are saying we can't make changes until we get the data, but getting data can sometimes be difficult. The payers also are avoiding the use of standardized contracts and in lieu of customized contracts, again, allowing payers to sort of maximize benefits for themselves and making it more difficult for providers to compare contracts within their payer group. And this lack of standardization is perhaps by design, again, making it difficult for providers to really understand. So if not make it impossible really for them to compare comparing contracts. And that makes, again, contracts less enforceable. The other emerging models in value-based cares, we're beginning to see as well models between payers and CMS with evidence-based care discounts or enhancements and product or service guarantees and risk share by product. And by product, we mean here the products that payers have for the various different market segments. So self-insured groups, small businesses, large employers, again, depending on the market and tweak the contracts for each market segment. Whereas on the provider side, we would recommend perhaps looking at governmental programs, which avoids these pitfalls as an organization is getting ready for value-based contracting. Again, focusing on programs that would have greater transparency and always risk adjusted. Infrastructure to address social determinants is also something that we are seeing in providers more and more, and hasn't seemed to really become much of a trend among payers. But we are recognizing, of course, that, and I'm sure everybody has heard this before, but that zip code is a greater determinant of your health and well-being than your genetic code. And so we certainly providers are beginning to look at this more aggressively and understanding where housing instability or food insecurity, where you lived, the toxins you're exposed to, how much exercise you get, whether you're smoking, and various other issues, how that affects your overall health. And one last point here would be that we would encourage that payers should invest in as much as you can to push burden of providing services back onto the payers. And that would be over regard to discharge planning, home services, and DME. So Dr. Seth, please.
I think that I wanted to add one more thing is that, like Dr. Jaeger said, if zip code is a bigger determinant than your genetic code, then make sure you understand your zip codes, your primary service areas, your secondary service areas. What are the zip codes? What are you facing? Because that should influence your benchmarks. You know, how much can you achieve, either on quality or on cost, based on the social issues that, that sort of are determined now by a commonality of residents in a particular zip code. And I think that that's something that Dr. Jaeger and I have been struggling with, is that some of these, are they trends or they just a Bandaid approach to the next round of discussions? And Dr. Jaeger, haven't we begin to read this and see this in all the literature and in our experience?
Yes. We were talking about, was Band-Aid the right term? And it probably yes, because superficial, temporary, but if you really begin to hemorrhage, it's not going to do much. We are seeing that, as we've mentioned, the surgical subspecialties or providers that are relying heavily on encounters and procedures are being hardest hit. But independent primary care practices are also being impacted. And I think I mentioned this earlier, about half of their yearly revenue due to delayed non-urgent care, including well visits and elective procedures. It's a recent study found that about 50% of primary care practices don't know whether they would have enough cash flow to continue practicing. And about a fifth of those surveyed expected to close within the subsequent 4 weeks. And as early as April, over 50% of ACOs in downside risk value-based contracts through Medicare shared savings said that coronavirus-related financial struggles might actually drive them out of the shared savings program. So despite the fact that we're seeing increases in telehealth, this is really just not making up for the loss of income. And in the short term, CMS is attempting to support providers remaining in value-based contracts with several temporary Bandaid measures, again, in an effort to help providers weather this current pandemic storm. Private payers are, I'm sorry?
I was going to say that, you know, I know in April, all the ACOs were like, what is going to happen to us? In fact, if we look at our curve, and we presented this in our second webinar, where we think that because of reduced overall expenditures, we can't imagine an ACO underperforming or performing above their benchmark. I think it's going to be the reverse. And I know we're running up on time, but this slide and our next two slides, we felt that, and there's one actually really good slide that Dr. Jaeger helped, let me just bring that up, is that between the waste in healthcare spending that is certainly identified in these different categories of failure of care delivery or failure of care coordination or over-treatment, certainly pricing is playing such a big role, and I don't think we can address that, but certainly fraud and abuse and all the administrative burdens. Combining this with the COVID situation, you've got to combine both these pieces into your next discussion or contract negotiations. So we're down to the last 10 or 15 minutes. I want to leave some time for questions, but we feel that both COVID-like conditions are going to occur again, may not be to the same, hopefully not to the same size and impact, but it's certainly going to occur. Chronic conditions, social determinants, and then of course all the waste and fraud and abuse that we see in the system. You need to take a position on each one and present your strengths of addressing that in your new contract negotiation. So I think we're going to just stop here for a second and leave it open for some discussion or questions so we can answer a few. Garrett, I think that's where we would love to take a pause.
Okay, great. Yes, thank you guys. That was a wonderful and very insightful presentation. We do have a few questions that came in, and so would like to get to those. Unfortunately, we can't get to all of them today, but in no particular order. The first question is, how can you structure a contract for comprehensive services if the agreement is based on fixed cost? And in addition to that, how does that incorporate the flexibility needed for unexpected expenses like pandemics?
So, couple of points. One is when comprehensive services and fixed costs can be complementary to each other, but they could be in opposite directions. And that's where knowing your network's capabilities and services and of course negotiating exclusions as well as the cost of services that you do not provide, both the making available those services to the same patient population as well as the costs associated with that, you should try and negotiate out of your contract. So that's how I would address that first part. And Garrett, could you repeat the second part of that question?
Yeah, sure. And how does that incorporate the flexibility needed for unexpected expenses, e.g. pandemics?
I mean, now that we have learned and everybody has that experience, it's a much easier topic to address. Of course, without that, it would not have been. But unexpected expenses are addressed by using that individual cap number. So if you could negotiate a lower cap, you eliminate the probability of being impacted negatively by unexpected costs per patient. And not everything is answered by that, but certainly that's one of the key factors or key points to make sure that unexpected costs don't creep into your total cost of care.
Okay, great. Next question is, what should worry us the most in the risk-based contract agreement, and how do we control for that issue?
What should worry you the most in a risk-based agreement is that you have a definable, manageable culture of your own organization. And by that I mean, if not everybody's on the same page, the hospital, the physicians, the diagnosticians, the ambulatory surgery centers, everybody needs to be on the same perspective or have the same perspective of eliminating waste by eliminating unnecessary stuff and cost. That's your biggest risk. If you don't know the culture of an organization, then don't enter into risk. And as a company, when we go in to advise a client on value-based care or risk-based contracts, and they ask us, will we be willing to take risk? That's the first thing we look at is what is the culture of the organization, and you can't determine that from data. You have to talk to the ACO, the providers in the hospital, and determine that are they willing to take guidance? Are they coachable? Because if they're not coachable, you can't put them on the team, And so I think that's the biggest risk in a risk-based contract. The second part is, it's all a marketplace situation. How do you hedge your bets? How do you buy reinsurance? You can mitigate a lot of the other risk factors, illness, risk score, but what you can't mitigate is if the culture of the organization is not aligned with the program.
Okay, great. Next question is, what is the difference between percent of premium and MLR?
I think they're used interchangeably. Percentage of premium, typically a payer will negotiate on a percentage of premium to make sure their P&L is working right, and that happens with the large employers and the small employers. The self-insured population is basically based on a P&L, both for the payer as well as for the employer. An MLR situation is where the premiums are fixed, and Medicare Advantage plans and Medicaid plans typically end up being an MLR type discussion because the payer is bound by the rules of spending 85% or so of the premium dollar on healthcare. And I think the Kaiser Family Foundation a couple of months ago put out an article saying that they anticipate all the managed care companies that participate in the Medicaid expansion program will have to return billions of dollars in premiums to the government because there has been such a marked reduction in use of healthcare services and therefore healthcare expenditure.
Got it. Okay, we have time for one last question. And that question is, today, Modern Healthcare reported that United Healthcare's net income nearly doubled during the second quarter of 2020 compared to last year. The MLR dropped from 70.2% from 83.1% last year for the same period. Under a full risk provider contract, would such profits and savings come directly to the providers?
Yeah. I mean, that's why we are saying we disagree with the ACOs that are saying we need to move out of becoming an ACO. No, go the other direction. Take more. I mean, in this situation, I think the accountable care organizations or the provider organizations that participated in this kind of risk-based agreements absolutely have the upper hand. But, we know that sometimes the payers squeeze in this unilateral contract changes that we have no control over. And I'm afraid some of that could begin to appear as the payers see that this profit that United could keep, now it has to share. So think about it from a corporate perspective. Hey, why should I give out $100 million to a particular ACO group when I can keep more of it? And they try to finagle out of it. But yeah, I mean, that's exactly what we are preaching, is move to risk, but understand your culture. Like the first question was, what is the highest risk? But if you understand your culture and your organization is moving lock, stock, and barrel, you will do well.
Great. Unfortunately, that's all the time we have today for questions. Thank you both again so much for this presentation. It was very informative. And if you did submit a question and it was not answered during the Q&A session, we'll be happy to answer it through email afterwards. And as we conclude, I'd like to encourage you to visit the HealthEC exhibit booth on acoexhibithall.com. To learn more about them and connect with their team. And this is also where you can find the recording of today's session in the library archive, as well as part 1 and 2, by the way, to get caught up. And the slides are all there and available for download. And so those can be found in the reference library. And lastly, if you have any specific questions for either Dr. Seth or Dr. Jaeger or the HealthEC team, their contact information is here on the screen. So feel free to make a note of that and to contact them directly, and they'll be happy to follow up with you for further discussion. Thank you all for attending today. I hope you found the presentation helpful and timely as I did. And have a great rest of your day and stay safe.
Thank you all.
Thank you, everybody.